Now it's time for our keynote. So Diane Ashiru-Oredope is going to join us, and she's the lead pharmacist for healthcare-associated infections and antimicrobial resistance at the UK Health Security Agency, honorary chair and professor of pharmaceutical public health at the University of Nottingham, and has recently had a period of time as the deputy chief scientist at the Royal Pharmaceutical Society. I'm really excited to hear Diane speak this morning, a real pharmacist idol, I think.
Thank you very much for your kind words. Really great to be here today, and thank you for the invite. As Vicky said, I lead on antimicrobial resistance and antimicrobial stewardship at UKHC. I'm the lead pharmacist for that. Very, very, very proudly a pharmacist. I tell that all the time, particularly to early career pharmacists, because it's a great profession to be in. But today what I'm going to talk to you about is around data, and how that data and how we've used that data for impact in tackling antimicrobial resistance. Many of you in the room here, I don't need to tell you about the importance of antimicrobial resistance, why we need to focus on tackling it, the fact that it's a global challenge, but it's also a patient safety issue. So many people are involved in what I'm about to talk about. I'm standing here on behalf of several colleagues across UKHSA, our SBAR partners, I'll talk about that shortly, as well as members of NHS England APMO team. So that's the Antimicrobial Prescribing Medicines Optimization Group. So when we talk about medicines data, it is around any data about use of medicine. And it's really great. I was standing upstairs listening in to just see some of the presentations earlier. And some of what I will talk about is already covered, but I will skip through those slides. But I think it's important that we just have a starting point around that for my context. And when I'm also talking, I'm talking around how we've used that data from a national perspective in the main, and how we've moved that from data to informing action, and then also then informing policy. So use of data, the data can be any, it can be prescribing, consumption. I think I saw on one of the slides where we cancelled out the prescribing because it's actually dispensed data, appropriateness. It can also be audit, survey, online portal, and then we have it at different levels. We have the local, regional, national, and international. I'm mainly going to talk around the national data set. And it's, again, there's also then data around what you have available, the visualization of the data, accessibility, and then the platform that is available. For primary care, obviously, because of the dispensed data, because of reimbursement, we have rich data there. But whilst we're talking now, Colin will remember this, in 2013, when we started SBAR, there was no way of collecting data beyond the primary care, and even then it wasn't in one place, and we didn't have as much source for one source of truth. So in terms of antimicrobial stewardship, it's often, the official definition according to NICE is that it's organizational and system-wide approach to promote and monitor judicious use of antimicrobials to preserve future effectiveness. But at the end of the day, it's about patient safety, and I keep coming back to that. And there are individual actions that people need to take as well. Antimicrobial stewardship is one of the key components of tackling antimicrobial resistance. The very first is infection prevention and control, because if we're preventing infections, we don't need to use the antimicrobials, and so on. So why is data critical to stewardship? We can use it for benchmarking and comparison, informing prescribing practice. We can use it to measure impact, drive action, and then enable innovation. And that drive action and enable innovation is really critical for us from a national perspective point of view. Benchmarking and comparison is also important, but that driving action is key. In the National Action Plan, we are on our third one, so I've been in UKHC and predecessor organizations since 2010, so we've had the 2013 to 2018 National Action Plan, the 2019 to 23, we're now on the 24 to 2029. And over those iterations, things have moved on in how we frame tackling antimicrobial resistance. The core components are still there. Preventing infections, antimicrobial stewardship, what we call them may slightly differ. But within this, the NAP places an emphasis on the role of data and surveillance as the foundation for tackling AMR, the importance of strengthening surveillance to track resistance and predict the spread, but more importantly, to use data to guide policy and clinical decisions, and also data for action. So there is a specific outcome within the National Action Plan called Using Information for Action. And then obviously we've got the stewardship and disposal. It's an interesting process trying to develop a National Action Plan and what then ends up being published and how we move things together. And over time I've learned around, evidence-informed and evidence-based, and actually across the world, policy-wise, I think I try to say this now to colleagues, is being aware that evidence-informed is quite key in national policy making. Evidence-based is important, so we take the evidence, but there's so many other things that need to be considered before that policy is made. This slide here, people may argue about, and there may be different opinion, and the colleagues who lead on Prescript, open prescribing, RX Info, I don't think IQV is here, are here. So you may argue where I've put the different ticks, but this was just a way to show that we have a lot of data visualization tools. And what's that's really important for those at a local level, those who are doing, taking data for action at a local or regional level, is we don't really need to be in a space where we're analyzing data from scratch again. There's so much out there that we can use as a starting basis. And then the data source for primary care EPACs we've talked about already, and then RX Info and IQV for us are quite key. SBAR I've put there, but that's more of a national data set and reports that we have annually. So EPAC2, I'm not going to go into the details, but just in case you haven't seen, there's several dashboards, and that's the colleagues in NHS England, the APMO team have really worked with the EPAC2 team to really try and have dashboards that can inform action. An example of how that EPAC2 has gone on to help national policy or to contribute to national work is the Pharmacy First data. Many of you may be aware of that, but in that we've got data set which is linking antimicrobial and antibiotic-sparing medicines supply in a standardized diagnosis for 7 common infections. Many of you in the room will know that Pharmacy First has got an interesting perception in the public, and in the days where X and Twitter was a bit more lively for healthcare professionals, there was a lot of discussion on there. But what we are seeing through Pharmacy First is that actually that there is use of antimicrobials, but there is use of other antibiotic-sparing agents as well, and the pharmacists are following the algorithms. There's a very, very tight algorithm that needs to be followed there, and we've published that data. So NHS England are obviously leading on this. There is an evaluation, a research-based evaluation led by London School of Hygiene and Tropical Medicine, University of Nottingham, and a few other academic institutions to work together in terms of the evaluation, but in the meantime, from a policies perspective, that is all being monitored and published as well. We're the only country where our data is so open, so I tend to present across different parts of Europe particularly, and they're always surprised at how open our data is, and I think that's something for us to be proud about, and hopefully then use for action, continued action. In the literature though, and this is one I'll just come up in a bit of, is we don't have so many other areas of health. There's information about use of medicines and published in peer-reviewed publication. For antimicrobials and stewardship, there isn't as much, and I know there were a couple that have been published recently from open prescribing, but we're not seeing enough of how people are using that data going into academic publications. So again, how the EPAC data or the primary care data is used is for our national surveillance, so our targets. So we do have national targets for the antimicrobial resistance national action plan, and that we want to reduce total prescribing, and also that for antibiotics, we want the aware category, so that's the how antibiotics are classified as access, watch and reserve, access being the usual narrow spectrum antibiotics. We want that to be 70% of all prescriptions. And I will say that we had that target before we became the global target. Ours is slightly harder in the UK because we have chosen to put carmoxyclav in the watch category rather than access category, which is what WHO have it. But again, you can see here how we use that primary care data within our National Action Plan and also using it for monitoring and also to take action. This year, we started to get inkling around private prescriptions and what was going on a couple of years ago. And so as part of ESPA, we put together a group to just look at that. And it's a small box in the ESPA report, but caused me the most challenge in terms of what we found, and I'll talk about that shortly, but this is just an example of how the data looks. Then we have RxInfo, who provide data to us for secondary care, and obviously they are a member of ESPA and have been a member of ESPA since 2013 when we initiated ESPA. I'm very grateful for that collaboration between RxInfo, IQVIA, and other organizations as well. Colin has already talked about RxInfo. What the key part for us is that we use that within the standard contract that we report back to NHS England, and then they use that for their policy policy activities. So then IQVIA. IQVIA, many of you will be aware of, but for us, from the data we publish overall in the ESPA, that comes from IQVIA for secondary care. So we then had to work with them and reimburse to be able to access data around private prescriptions. And what we found is that 22% of all prescriptions in primary care are now from the private non-NHS sectors. So, you know, when you look at the data and you just think, well, I'll present this at the different groups I present at. So I did that. And yeah, it was a small box in ESPA, but that has caused quite a big discussion point, including, rightly so, questions from ministers. What are we going to do about it? So this is an example of how data is now moving about what are we going to do next? Because we now have this information, and I often say we cannot keep admiring the problem. So there is a challenge there. So what are we going to do about it? We don't have the solutions yet, and the first step is the surveillance data. So within ESPA, we have multiple chapters. We have data on the bugs and the resistance. We have data on research insights. How many more minutes do I have, Vicky, please? 7 more minutes, okay, fine. Knowledge mobilization is quite key for us. So we ask what people think about our surveillance report and how that is being used. And you can see there that it's used for reading for information, but also some are using it to develop local indicators. It's being used for research. It's being used to inform policy as well. This is our journey so far in terms of consumption. And I think this is really important because sometimes we get pushed back on, well, we're not seeing reductions. And what people don't see or don't remember is that we were on an upward trajectory before we started publishing data and started using that data, not only having the data available, but publishing it and then thinking about how we're going to use that for action, how is that going to inform policy. So 2010, you can see 2010, 2012, we were the antibiotic use data was continuing to increase. And then in 2013, ESPA was established. Myself, Susan Hopkins, and quite a few colleagues within Public Health England, as we were then, initiated that, and working with colleagues across England. We have colleagues from across Scotland, Wales, and Northern Ireland as well, but ESPA is about England. So what you can see there is that, you know, that upward trajectory, but now what we've had a reduction. Obviously, during COVID, we had much bigger reductions, and then things are starting to creep back up again, and we're now at pre-pandemic levels, as we say. But what I strongly believe is that if we didn't have the data, if we were not using the data for action, what we would have is that continued increase in antimicrobial use. And where would we then be in terms of resistant infections? A timeline of different, so that is NHS Improvement and Assurance Scheme, so that's led by NHS England, have taken place over time using the data. So sequence, quality premiums, have all NHS oversight framework. These are all based on data that we have on antimicrobial use, and then using that to develop interventions. There were other improvement schemes. So we've talked earlier about the pharmacy first one. There's NHS oversight framework. There's the medicines optimization opportunities. And then there's the NHS standard contract. As many of you will know, there isn't actually money available anymore for these. But I think the fact that they are still priority and the colleagues working hard to ensure that the visibility remains for this is showing good improvement. This is an example of where we picked up data from Open Safely, and we started hearing around long-term and repeated antibiotics, and sometimes we start from different places. People often talking about repeated and long-term antibiotics, and it keeps coming up as a conversation, so we thought, what can we do about it? Thankfully, with Open Safely, that was really useful for us, and we were able to analyze the data to see where the repeated and long-term antibiotics, when we found out that it was mostly for COPD, UTIs, and acne. And as a result of that, we then developed a national intervention how-to guides, which is part of the Target toolkit. So again, how to use, it's not direct medicines data, but we were pulling out prescriptions or diagnosis codes within Open Safely to, in terms of people who have had and same antibiotics prescribed 3 times in a 6 months period. And that's how we determine that. Sepsis, again, this was not antimicrobial specifically, but again, it's use of data, and this is an important one where we had a national guidance developed and didn't have any information around inequalities. And at that time, post-COVID, in my head, it was quite challenging that should happen. But I knew that we didn't have data available, or there was nothing in the literature from the UK. It was mostly from America, and most people will say, well, we have a different health system, so it's different. Fair enough. But again, with an academic partnership with the University of Manchester using Open Safely data, we analysed that, and actually what we saw was significant levels of inequalities, but not just in the usual factors associated with health inequalities. We were seeing around learning disabilities, COPD, and also other comorbidities as well. And the University of Manchester put that through as a press release that we didn't think would get traction. 490 million hits across all the broadsheets, apart from Financial Times. I guess there was no money involved in that. But for us, and that again has helped us to take action over time. And that's now, because that was now published evidence, that NICE guidance, and the last time when I looked at it and there was a consultation out, they have picked up on some of those key new groups that we identified as a result of analysing Open Safely data. We were able to actually analyse Open Safely data. I knew about it because we had used it for the long-term and repeated antibiotics medicines use data, and that's helped us to build into other areas. In terms of supporting local and regional actions from UKHSA point of view, we have the AMR local indicators on fingertips, and that has 6 domains supporting NHS England initiatives: AMR, prescribing, healthcare-associated infections, IPC, and also stewardship. So things like the vaccination rates of staff, a whole range of different indicators are all published there. So it's one-stop shop across the different domains of AMR. And then, I know why that. So that was meant to show that, open data, as I said, across the world, anyone can go onto fingertips and look at data for ICBs, for trust. And so again, if you sit right here now, open your phone and go to fingertips, you will be able to look at the area that you're working in, look at the data for that trust across a whole range of different indicators. PressQuip is an important one. There's really, again, NHS England colleagues have worked with them to have a stewardship platform within that, which is open access. And again, they've been using that to really talk about some of the key initiatives, the national steers, or where they want to try and improvements to happen. For example, children and antibiotic use has had really good impact on the dashboards there. Open prescribing, I'm not going to talk about that because you all know about it, is another example of where local to regional local and regional action can take place. NHS England have a data work stream on their web, on the Futures NHS, where you can go there to look at data and also a whole range of different opportunities there to access on links to the different data sets that are available. In UKHSA, we're starting to develop a data dashboard. At the moment, it's mainly focused on antimicrobial resistance and infections, but over time, we'll build in some more around antimicrobial use. So for us, from a national policy perspective, we identify a problem or we are aware of an issue, we research the question, think about an intervention, and the way we research or identify the issue could be data-driven, could be because of focus groups or discussions, but we need to make sure that we have an evidence base for that. And then we develop an intervention, and that intervention could be a tool, but could also be a policy, and then we implement. Knowledge mobilization has become even more and more important for us, and we're doing that. I'm going to move on now to health inequalities. How many more minutes do I have? 2 more minutes, I'm almost done. Health inequalities in terms of the NAP development, again, how data has helped us to get to national policy action. So we started to see in the SBAR report differences in resistance data for ethnic minorities and then social deprivation. Often what we get is, what can we do about it? Fair enough. But the data, it wasn't changing. And so at this time, all we knew was that there was a difference between the most deprived and the least deprived, and that difference was widening. And it just didn't make sense. And so when we went into developing the National Action Plan across the 4 UK nations, the question is, what are we going to do about this? And how can we have a focused attention on this? And if we didn't have that data, I know that if I'd gotten into that group, I was asked to lead that, co-lead the group, I wouldn't have been able to push back on there's nothing we can do about this, let's move on. And again, I use that word, we can't keep admiring the problem, and I use that same phrase because it was there, the data is there, there's an issue, the data's not perfect, but we know that there's something wrong and we have to take action on it. So what's happened is that in the National Action Plan, there are 9 outcomes, 30 commitments. One of those is around inequalities, and the focus is around data on health inequalities. So how do we make sure we have better data, developing a toolkit to address inequalities, and then developing interventions to focus on reducing that inequality gap that we are seeing. We're using inequalities rather than inequity within UKHSA. We say inequity because that's the unfair. At the moment, the data shows us there's inequalities. We don't know yet whether or not it's fair or unfair. An example of the commitment is around the data. So with antimicrobial consumption, so the medicines data, previously all we could show was regional variation, and then with better data through EPACT, we could start to do variation by age group, and now we can also have data by indices of multiple deprivation. So again, looking at those differences. That graph at the top, I think is your right, there shows you how we've moved from a difference of 29% to now having a difference of 47% between the least and most deprived in terms of incidence of resistant infections. From a consumption perspective, again, we publish that data across regions. We publish it around indices of multiple deprivation as well. Next phase for us is really now understanding this private non-NHS routes for antibiotic prescriptions, further work to collect patient-linked data and disparities. Important to know that having the data is one step. We need that multi-pronged approach, the feedback, the education, public engagement, behavior science. Can't talk without, I don't think anyone's talked about AI yet, so I'm going to mention AI. I think that's going to, it is here, and so it's thinking about what are we going to do. And people are already starting to research in the context of AMI, in the context of stewardship, so it's something to think about, how is that going to influence on what we can do. This is a paper that was written by Professor Ben Goldacre around the fact that, there were 185 recommendations though, and how we're going to make better use of data, how are we going to access the data. Data access, data linkage is an issue. So it's going to continue to be a challenge. So I'm going to finalize to say that antimicrobial consumption data is key, is critical. It has definitely supported us to influence on antimicrobial stewardship and to tackle antimicrobial resistance. And I hope that you continue to join us on that journey in the area of antimicrobial resistance, but other areas of health as well. Thank you.
Brilliant. Thank you, Diane. We have a number of questions, but we've just picked one, hopefully quick one. So what impact do you think the single national formulary will have on antibiotic prescribing, if any?
I'm going to deflect on that question because it's a political question. So I would say we can ask David Webb, the Chief Pharmaceutical Officer, when he presents later on. I do think that it's going to, the single formulary is important, but as you can see, there are a whole range of topics around that. And I think from my role at UKHSA, I wouldn't be able to answer that. But what I do want to say is that having one data place that we can link data that we can use, one source of the truth is so important. But more importantly is people taking action when they have that data, because there's no point in having data for data's sake or having a formulary for formulary's sake. So thank you.
Brilliant. Thank you.